Thank you so much. I'm Daniel Schecter. I'm a family physician. I started the Cannabinoid Medical Clinic, and I started the first clinic back in 2014. We started with one clinic at Yonge and Eglinton, and over the past 3 years, we have received over 35,000 referrals from different family physicians and specialists, just to give you an idea about the massive interest in cannabinoids as a therapeutic option. What I'd like to talk about today is really give you a bit of an understanding or an introduction to the endocannabinoid system, which goes to the very heart of understanding why cannabinoids as a therapeutic class actually work. And also help you understand how cannabis might be beneficial to manage pain as well as their associated conditions, because obviously pain does not live on its own. It's not siloed. We have a host of other medical comorbidities that go with this, especially when we're talking about Ehlers-Danlos syndrome. And as Dr. McLeod said, it's not just one system, it is every single system. And what's nice about the endocannabinoid system is that it affects every single system. So in a way, it's a great alternative therapy for certain people. For myself, I really became interested in cannabinoid medicine actually when I was studying with Dr. Mark Ware in Montreal. That's when I first became aware that we actually had something called the endocannabinoid system. But I went through medical school, I was a young physician, I went through residency, and I was taught guidelines. I was taught that if you follow your guidelines, you are going to be an excellent doctor and your patients are going to get better. But after being in practice for a couple of years, I started hearing the following story. Patients would come to me and they'd say, "Doc, you've been treating me for a few years now with chronic pain, and you've given me 6 different medications, and I'm not any better. I'm not able to get back to work. I'm not able to spend time out of bed. I'm not able to go for a walk. And I have all these side effects, constipation, lethargy. Don't you have anything better?" And I'd be scratching my head. Then they would come back, often with a little bit of a sheepish grin on their face, and they would say to me, "Doc, I want to tell you something. The other day, my son brought me a joint, and I decided to try it. I haven't used it since the 60s, but I said, why not? And for the first time in as long as I could remember, I felt a little bit better. I felt like I wasn't bothered by the pain as much. My pain was diminished, and I was able to sit and have fun and actually interact and be mindful with my family." And for me, when I heard that over and over and over, and I was aware of the endocannabinoid system, I said, you know what, cannabinoids might be a great option for a number of patients. And that's really how I became more interested in cannabinoids as a therapeutic option. And when you ask patients, how do they work for you? How do you like it when you compare it to other therapies? Invariably, they're going to tell you that, you know what, it's a great alternative for me. Now, we are increasingly understanding that cannabinoids are an entire therapeutic class of medication and that they belong within a treatment guidelines or how we should be approaching chronic pain. This is a Canadian Pain Society's guideline from 2014 with regards to chronic neuropathic pain. They put cannabinoids as a third-line agent, but I would even argue that we should consider it as a second-line agent, on par at least with opioids, if not before, because we are getting increasingly aware that opioids are not that very effective for chronic neuropathic pain in particular. And it's not just, Canadians who are weed crazy that are going to be legalizing cannabis next year that consider cannabinoids as a therapeutic option. There's also the European Federation of Neurological Societies and a number of other societies. And cannabis as a medication is not something that's new. It goes back 5,000 years to ancient China. It's been used in every civilization since. It came out of favor in the West. It kind of got forgotten about over the Middle Ages. And it was a British physician by the name of O'Shaughnessy who went to India and actually rediscovered it and brought it back to the West. And it became incredibly popular from the 1850s up until the mid-20th century. It was so popular that every single drug company had cannabis-based medicine. It was part of you could walk into any single pharmacy or look into any single physician's black bag and find cannabis tincture. It was so popular, it was considered Queen Victoria's favorite medication to help treat menstrual cramps. Now, cannabis came out of favor in 1937 when it was made illegal in the United States for economic, social, political reasons, as well as for medical reasons. There was the invention of morphine, the hypodermic needle. And when it became illegal in 1937, the American Medical Association were categorically against it because they realized that cannabis had significant therapeutic benefits. Now, we kind of forgot about cannabis up until the late 20th century, but ever since then, there was an incredible amount of interest that we developed again into cannabinoids. And in Canada, we've had access to medical cannabis since 2001. And as of last year, we've had over 23 countries around the world and over half the states in the US that have approved cannabis for medical purposes. And why is that? It's because we understand now that we have something in our body called the endocannabinoid system, or the body's own cannabis system. Now, basically, the endocannabinoid system, one of the most important parts of it are cannabinoids. Cannabinoids really represents a whole class of molecule that interacts with the body by interacting with specific receptors called cannabinoid receptors. And we produce these molecules naturally in our body. They're endocannabinoids. They're found in nature in highest quantity and density in the cannabis plant. And they can also be made synthetically into pills, such as nabilone. Now, the endocannabinoid system is increasingly being understood to be an incredibly important system across a wide range of different physiologic and pathophysiologic conditions. We know it's involved in homeostasis, so it keeps the body in balance with regards to pain, with regards to sleep, appetite, digestion, anxiety. So you can understand why it's such an interesting component. The endocannabinoid system, just like any other neuromodulatory system, actually has a number of different components. It has those cannabinoids that we produce naturally in the body. They can bind to specific cannabinoid receptors. There's 2 of them that have been identified, cannabinoid receptors 1 and 2. And then there's enzymes that create and break them down. Now, the endocannabinoid system, one of the main areas that it takes place is at the level of the central nervous system. This is a picture of 2 neurons. And what we find is that usually information is transmitted from the first the first neuron down to the second. And what happens with the endocannabinoid system is that the endocannabinoid system has these cannabinoid receptors on the cell surface of the first terminal. And when they're stimulated, either by our body's own cannabinoids or by plant-based cannabinoids or synthetic cannabinoids, what it does is that it actually puts a stop to the release of neurotransmitters, which has to do with information being passed from one cell to the next. So it really can change the tone of your central nervous system. It can modulate the amount of information that goes from one cell to the next, which is incredibly important when we're thinking about conditions like neuropathic pain, anxiety, spasticity, anxiety, which has to do with neurons basically either going too fast or providing wrong information from one cell to the next. So if we can modulate the endocannabinoid system and turn down the tone, we can achieve very effective symptomatic control of things like pain, of anxiety, of spasticity. And if we look at the distribution of cannabinoid receptors within the central nervous system, we actually have almost no cannabinoid receptors that are found within the brainstem. And that's important because that's where you have cardiorespiratory drive, and there's a lot of opioid receptors there. So we give too many opioid receptors, and it can flood that area. Or we give too many opioids, it floods that area, it floods the opioid receptors, it causes an overdose and death. The same is not true with cannabis because there's few cannabinoid receptors in the brainstem. It's virtually impossible to provide enough cannabinoids in order to induce respiratory depression and death. And that's why they say cannabis is safer than peanuts. It hasn't killed anyone in terms of a toxic overdose. Now, what is it that we refer to when we talk about marijuana or weed or pot or ganja or dope? Well, those are all slang terms, and they are slang terms that refer to a very specific portion of the cannabis plant. The cannabis plant is a genus of plant. It has a few different species. It has males and females, and cannabis or marijuana, pot, weed, actually refers to the flowering buds of the female cannabis plant. Those flowering buds, if we look at it under a microscope and analyze it, it has over 450 different compounds, many of which are cannabinoids, but there are two cannabinoids found in higher concentration than all others that are thought to be responsible for the vast physiologic actions that cannabis can produce. Those two molecules are delta-9 tetrahydrocannabinol, or THC, and cannabidiol, or CBD. Now, THC is the only cannabinoid that is found in the plant in high enough concentration to make you feel high. Now, cannabis that is used or sourced for recreational purposes has actually been grown and selectively bred over the generations to have increasing amounts of THC, to the detriment of CBD and everything else. Now, just because THC makes you high, it doesn't mean there's no physiologic benefits. THC is an excellent for chronic pain. It's good for spasticity, for nausea, as an appetite stimulant. So THC makes you high, causes those physiologic effects, whereas CBD doesn't make you high and will decrease how high you get from THC. CBD is also being investigated as an anti-anxiety, an antipsychotic. It has been shown to be an effective anti-inflammatory, so it can help with pain in that respect. And it's also being looked at as an anti-epileptic. I'm sure many of you have heard stories of people using CBD oil in order to treat treatment-resistant epilepsy. And it's often the ratio between THC and CBD that provides the specific effects. Patients will say, I use a high CBD variety in the morning or a high THC in the evening, depending on what symptoms that they want to target the most. Now, in Canada, it's not just herbal cannabis that we have available. Cannabinoids are an entire group of medication. We have those that have a drug identification number that you can get in the pharmacy available with a prescription from your doctor. And then we have the herbal cannabis, its extracts and derivatives that don't have a drug identification number and are, in general, not covered under your insurance plans. Now, nabilone is a synthetic cannabinoid. It's very similar in structure to THC, which means that it has all of the benefits of THC. It's great for spasticity, for nausea, for vomiting, for pain, but it has all of the side effects of THC as well. And those side effects are on steroids because it doesn't have the CBD or the other molecules to modulate those side effects. So nabilone is great because it's covered under all public and private insurance plans. And the problem is that it can be very hard to tolerate. At the moment, unfortunately, it's also on back order, which is extremely frustrating for a lot of my patients who are on ODSP, who are on social assistance, who don't have medication coverage and can't afford herbal cannabis, but do find that nabilone is effective for them. The other medication available in the pharmacy is Sativex or nabiximols. Unlike nabilone, it's not a synthetic cannabinoid. It's actually an extract of the herbal cannabis plant that delivers in a spray format standardized amounts of THC and CBD. Every spray gives you 2.5 milligrams of each. It gets absorbed through the oral mucosa, so you put it on the inside of your cheek and it gets absorbed that way. Unfortunately, while it does have a DIN, it is available in the pharmacies, it is not covered under almost any of the public and private insurance plans. One small bottle, a 10 ml vial, is about $275, which contains about $20 worth of cannabis oil. So for most people, if they want to use this, I would probably just recommend that they use herbal cannabis, which, unlike the other two medications, does not have a drug identification number, has no approved clinical indications, has 250 different varieties with a complete range of THC and CBD between less than 1% and over 25%. And it's available. You can purchase it either in the dried flower form or you can buy it in an oil form. So people would say, well, why would you want to use herbal cannabis when you have these two other medications? But it's because of the variability in modes of delivery, either inhaled or ingested. variability in terms of strains, where you can often find a strain of cannabis that works for you with minimal side effects that allows you to get control of your symptoms. So it's actually the variability and the options that exist within herbal cannabis are the reasons why we are actually using it more and more and find it superior very often to nabilone, although I'll say 30 to 50% of my patients are on either nabilone alone or a combination of nabilone and herbal cannabis. Now, does cannabis work? I know from my clinical practice that it does. If we look at systematic reviews and meta-analysis, they're going to tell us that there's moderate quality evidence to use it in chronic pain and spasticity. Patients will tell you overwhelmingly that it works. But when I have a patient in my clinic and they have tried 3, 4, 5, 6, 10 different medications or therapies, I'm not going to say, and they want to try cannabis, I'm not going to say, I'm sorry, there is not enough evidence to use cannabinoids in clinical practice, so you're not a candidate. I'm going to say, you know what, let's consider your case and your specific situation as an N of 1 study, meaning that I am going to consider you as an experiment, and we're going to have experiment with this medication. We're going to come up with very specific endpoints. We're going to say, we're going to start this medication. If you're able to achieve X, Y, Z functional goals, then it's a success and we can continue to use it. Now, we know chronic pain is an incredibly complex phenomenon. A third of Canadians will experience chronic pain. Almost probably 90% plus of EDS patients are going to experience chronic pain. It is an incredibly complex phenomena that needs a complex response, biopsychosocial, and one of those is going to be pharmaceutical agents. Unfortunately, we have had very few new classes of medication appear over the past 20 years, and we are relying overly on opioids despite increasing evidence and reports that opioids are not that effective over the long term and cause more harms than create solutions. And cannabinoids and modulating the endocannabinoid system is increasingly being understood as a rational option in order to approach this complex problem. We know that the endocannabinoid system is incredibly important in modulating our perceptions of pain. We know that cannabinoid receptors are located in all areas along the pain pathway, both peripherally in our nerves, in our muscles, in the spinal cord, as well as in our brain. And when you ask people, what does cannabis do for you who are living with chronic pain, they're going to tell me that it does two things, 99 times out of 100. The first thing that it does is that it will reduce their pain by about 3 points. It'll bring it from an 8 down to a 10. It doesn't eliminate it. It doesn't blast it away. The other thing that it does is that it makes them not care about their pain that much. It makes it more bearable. It doesn't get it away, but you know what? I know it's there. It's just not bothering me that much. I can sit there and be more mindful. I can be more present. And for the longest time, I was thinking, well, is it just because people are getting high? Is it just that they're so high they don't give a shit about their pain anymore? But that's actually, it's not the case. So people who are using cannabis actually do not use enough, as a medication, do not use enough cannabis to get high. They use 1 or 2 inhalations. They don't smoke in a whole joint. And they don't get high. They actually become more functional and more present and can be more active. And it's only since I've really started to delve into the endocannabinoid system that I've understood that the cannabinoid receptors and the way that cannabis works on the central nervous system is the very fact that you have cannabinoid receptors within the limbic system, the amygdala, the areas that have to do with emotion. And you don't need very much to actually affect that area of the brain to make it so that the pain is more palatable. Now, they recently did a study using functional MRIs to prove this concept. They brought people who have never tried cannabis, who have no chronic pain, and they put them into a functional MRI system. They put capsaicin cream on their skin, so it induced a pain response. They turned on the machines, and then they gave them small doses of THC. And what they found So what they found was that when they gave them small amounts of THC, the intensity of pain did not decrease, but the unpleasantness associated with that pain was significantly decreased, and their limbic system lit up like a Christmas tree. Now, we have a good number of studies to really support the role of using cannabis in chronic pain. Most of these studies are limited by their small number of subjects, their variable methodologies. This is one of them, done by Dr. Ware in Montreal. It brought a bunch of patients into the clinic, gave them either placebo or increasingly high doses of THC over a 5-day period. And what they found was there was a statistically significant improvement in their chronic pain at the higher doses. But what was really interesting about this is that aside from pain, they were also looking at sleep quality and anxiety. And I love this study because we know that people living with chronic pain have an incredibly high burden of other illnesses, problem sleeping, problem with anxiety, depression. And what we find with cannabis is when you provide cannabis to these patients, not only do they have improvement in their pain, but they have improvement in sleep, anxiety, appetite, and we can often reduce many of the medications that we're giving for all of these different conditions. Now, I know we're pretty much running out of time. I wanted to just run quickly through a few other ideas. One is that there's a very well-known opioid-sparing effect of cannabis. When you have patients who are on opioids, long-acting opioids, and we introduce cannabinoids, whether it's synthetic or herbal-based, they often achieve a 30% or more reduction in their opioid use, decrease the side effects of those opioids, and have the same amount of analgesic effect. There was a recent meta-analysis that looked at this very topic, and there's been a number of studies to show this. Cannabis currently is available in two formats. It's either available in the dried plant form, which is most often inhaled. The other way it's available is as an oil, which is meant to be ingested. These have different pharmacokinetics. Inhaled, it has an onset of action like that. It lasts 2 to 4 hours. Ingested, it takes 1 or 2 hours to take effect. It will last much longer. Obviously, we don't want people to smoke. We want them to vaporize. This is done by actually making the cannabinoids, which are suspended in this area of the plant within liquids, heats it up in an electronic machine. It heats it up to a point where the liquid containing the cannabinoids gets hot enough that it goes from a liquid to a steam, and you inhale that steam along with the active ingredients. So it's much safer than inhaling smoke. Obviously, we also have oils, which can be ingested. That has a specific amount of THC and CBD per milliliter of oil. You put it in your mouth, you swallow. It can be dosed very precisely, and it can be used out in public, in long-term care centers, etc. So it's a great way to be used, and some companies are even putting these into capsules. I mentioned before that cannabis can be safer than peanuts. Now, it's true that it is in terms of toxicity and lethality, but what drives me nuts about the cannabis advocates is that they don't respect the fact that cannabis affects the endocannabinoid system and can have a host of other side effects. So people just do not have the respect of cannabis as a substance that's physiologically active that can cause significant side effects and adverse events. And those include effects on the cardiovascular system because you have cannabinoid receptors throughout your body, including your heart, your arteries, your veins, but as well as a number of other systems. And that's because, again, the endocannabinoid system is expressed in every single system and tissue within our body. So it's not something that should be considered safer than peanuts necessarily. And it's not something that just makes you feel happy, hungry, and sleepy. That being said, when cannabis is used medically, it is used at a much lower dose than people who are using it recreationally. And a lot of the information that I had showed you before was extrapolated from recreational users. Only recently do we have a study looking at medical users to show that it is a relatively safe medication that has not shown any serious adverse events, but as would be expected, can provide increase in the risk of non-serious adverse events. So I just wanted to present that overall topic and review of cannabis in clinical practice. And I guess my take-home points are that the endocannabinoid system is a potentially valuable tool in order to target not only pain, but a number of other conditions and symptoms that are associated with people living with chronic pain. There's a number of options with regards to cannabinoids, not just herbal cannabis, a number of delivery options, and that it is a medication, not just a recreational drug. And we have to have some respect for it and speak to your physician and get referred to a cannabinoid specialist if you're interested. So thank you very much.